How's it going, guys? We have a medium difficulty question for cardio phys. We've got a 70-year-old dude who's having an MI. Okay, so we're not trying to make that hard. Even if you have no idea what we're looking at on the ECG, you don't even need it because clearly you've got a dude who's got hypertension, type 2 diabetes, all sorts of cardiovascular meds. And we were showing you an ECG here, so isn't he at risk for atherosclerotic disease and myocardial infarction? So he's got an inferior MI. He's got ST elevations and leads 2, 3 AVF. Okay, that's the right coronary artery in 85+% of people. The PDA comes off the right coronary. Made a clip on this the other day, but if you're left dominant instead, it means the PDA comes off the left coronary. But what's going to happen is you go left main coronary, left circumflex, and then the PDA for left dominant only, but right dominant is right coronary, goes straight to PDA. So USMLE can have the answer just right coronary artery in this case. Now, what are we going to see in the setting of a myocardial infarction? Well, for systemic vascular resistance, we're going to have an up arrow. If the heart's not pumping the way it's supposed to, and your cardiac output is reduced, doesn't it make sense that you're going to constrict your peripheral arterioles to compensate to increase pressure proximally? That's what's going to happen. All right. So you can think of it conceptually that way. You're like, yeah, that makes sense. Okay. More mechanistically, if you have reduced cardiac output and you're not perfusing your kidneys the way you're supposed to, aren't you going to have RAS upregulation, which means increased angiotensin II binding to AT receptors on systemic arterioles causing vasoconstriction? So that's actually more mechanistically that it's RAS upregulation secondary to angiotensin II in particular, in addition to catecholamines, right? So systemic vascular resistance is increased. And we're not focused on it here, but pulmonary capillary wedge pressure is increased in setting of cardiogenic shock. Exceedingly high yield equals left atrial pressure, backs up to the lungs. Increased pulmonary capillary transitation into the interstitium gives you pulmonary edema, all right, and dyspnea. So in terms of our bicarbonate here, it's going to be a down arrow if you're forced to choose, and this is because you got lactic acidosis in the setting of shock. Now, it's not limited to cardiogenic shock. It could be septic, hypovolemic, doesn't matter, okay? You might get an MI, the bicarb's 20, normal range 22, 28, and you're like, why the fuck's the bicarb low? It's lactic acidosis. They'll give you septic shock with appendicitis, and they'll tell you that there's a metabolic acidosis, and they ask why, and the answer is just lactic acidosis. So if you're not perfusing your tissues the way you're supposed to, then aren't you going to have decreased aerobic respiration, which means increased pyruvate shunted to lactate, more anaerobic respiration? So that's the mechanism. They want you to know that lactic acidosis, a high yield cause in USMLE, is shock. And more step 2, step 3 stuff, but it's not even limited to shock. You can have severe pulmonary embolism where blood pressure is not even low. It's not even an obstructive shock per se. You could have reduced bicarb, it's still lactic acidosis. So there are other instances. So bicarb's low, and then you're going to have increased left ventricular end diastolic volume, and that's simply because if your heart's not pumping the way you're supposed to, then you're going to have retained preload. Okay, so reduced ejection fraction in this case, and that increased volume is why you've got increased pressure in the setting of systolic dysfunction here. So higher volume, higher pressure, and it's backing up, as we talked about, with pulmonary capillary wedge pressure increased. Choice C, correct answer. You know the deal. 2 may work on time. Appreciate your time. That's it.